Hello, everyone. Good afternoon. This is Diane Solov. I'm with Better Health Partnership, and I'm pleased to welcome you to our first webinar in our four-part series on trauma-informed care. We've had a speaker substitution for our opening segment due to a family matter that arose for Kim Keel, the Trauma-Informed Care Project Coordinator for the Ohio Mental Health and Addiction Services Office. Elizabeth Boyle was kind enough to step in. Beth is a social worker and a trainer in trauma-informed care for the Ohio Department of Developmental Disabilities, who brings more than 17 years of experience in social work. Thank you, Beth, for joining us and for pinch hitting here. We welcome you and know you'll do a great job. There's a lot to cover in the part one of the series, so we'll get to it really quickly. A few fast housekeeping rules. Your computer and phones are placed on mute, and they will be for the duration of the presentation. If time permits, we will take questions at the end of Beth's presentation. Please add your question to the question box, and you'll receive a survey at the end of the program. Please take a moment to complete it. Your feedback is really important to us. And quick note, please mark your calendars for part 2 of the series on December 12th when Sue Marasco, Director of Education and Trauma Recovery Services at the May Dugan Center in Cleveland, will present on implementation of trauma-informed care. We're lucky to have Sue with us in person this afternoon. Beth, please take it from there. Thank you.
Great, thank you for the introduction. I'm really honored to be a part of this, this webinar series. So today we're going to talk about Ohio's Trauma-Informed Care Initiative. One thing, we are lucky in Ohio because we are the first state, one of the states to be a part of the trauma-informed care work. So our mission in Ohio is to advance the trauma-informed care in Ohio, just the understanding our mission to expand opportunities for Ohioans to receive trauma-informed interventions by enhancing efforts for practitioners, facilities, and agencies to become competent in trauma-informed practices. As we look at why is trauma important for us to look at as a system, and you know, it started out in our mental health system and a partnership with our Ohio Department of Developmental Disabilities and those two agencies looking at trauma and why it matters. And as the work has advanced, it started to look at, you know, putting those practices into laws. And so here are a list of, we'll go through briefly the laws in which have been transformed to include trauma-informed preventions and practices. So the first one is the Family First Prevention Series. This was a major reform in the child welfare system. We're looking at and attributing to what's happened to the person and providing services and service delivery based on that person's history. It requires that there's a written trauma-informed prevention plan to be created that attributes to the person's trauma history. The next bill is the next one is House Bill 318. That's Ohio legislation that will be effective next year, and it's actually with our university system, making sure that colleges are requiring instruction on a variety of TIC curriculum and trauma-informed care curriculum. And so, you know, thinking about the impact that that would have on college graduates and kind of having the trauma understanding when they go out to the field and into the professional world. The next is the Title 42 Public Health. These are rules and regulations for our nursing home facilities. It requires them to collect and respond history to help a person who has experienced trauma who resides in nursing homes. And I think, too, what happens when the law, when laws change and reform, it gives no choice. So we got to make it happen. We got to make sure that we're looking at a person's history and discovering their story to better support and serve the person in the most holistic possible way that we can. The next set of laws that we have attributed our work to as well is through the Office of the Ohio Attorney Generals. This talks about, we created 6 trauma recovery centers that focus on victims of violence and crime victims. The hospital team, they created this program where a hospital team comes in to help again just looking and triaging the mental health needs of a patient while considering their trauma history. The OPATA, which is our law enforcement curriculum and requirement for all law enforcement. Recently, this was in the last year, they developed a 6-hour course for trauma policing that addresses both the victim and the law enforcement officer and their experienced trauma, really attributing to secondary vicarious trauma that the police officer experiences and helping them understand how the things that they witness and see and intervene on in those crisis calls, how that it may impact them on the day-to-day and in their jobs and their life experiences in general. And so a really important shift in policy and a really important shift in the contributing of trauma-informed care policy and practices. The next one is the Ohio START. This is a program that was funded through a Victims of Crime Act grant from the Ohio Attorney General's office, which shared among 31 counties. They look at trauma that occurs in addicted families. A really critical piece and focus that we're all experiencing in society is looking at those addicted families, how the opioid crisis is affecting families. And the system has built a wraparound service to address the trauma experienced by both the kids and the adults in the family to help support a healthy atmosphere. They use a peer recovery model with that system and that program. And so looking at the family and how do we help the family heal maybe from what's happened to them, maybe victimized due to the drug use of the parent, and then provide them with specialized treatment for any resulting trauma, behavioral or emotional trauma that's occurred. So just looking at, why it matters, again, it's in our law now, so we have to do something about it. And so as we think about trauma events and traumatic things that have happened to people on a large scale or on an individual scale, it's great that our laws are now attributing and saying, hey, we got to really look at this. There is an impact to attributing time and effort to understanding where a person's been. So as we go through the training, you're going to, after completing the webinar, you will hopefully have a shared understanding of trauma, be able to identify examples of a traumatic event, understand how prevalent trauma histories are among the people that you support and serve. So it may sound simple, but we do need to highlight that because without safety and security, when we think about how do we approach or address trauma for a person? And there are some things just to keep in mind that when we're thinking about helping a person through their experience, that we have to establish and provide safety. And asking the question to the person, what helps you feel safe? Again, it may sound simple, but it has to be highlighted because without safety and security that is felt by a person, there's no progress or therapeutic relationship that will occur. We all know those important people in our lives that we can go to and rely on and talk with that make us feel safe, that makes us feel safe to share and really understand where we're coming from. There is always that underlying question of what happened to you. And so thinking about in our system, we typically are symptomatic, so we talk about what's wrong with you. When we come from a trauma lens and a trauma approach, we're really talking about what happened to you. There's nothing wrong with you. It's that something has happened to you that has maybe impacted the way in which you respond in a traumatic event, or something that's happened previous to you that makes you respond the way you do currently. So we think about symptoms as adaptation to traumatic events. They're not right or wrong. They are just someone's adaptations to what's happened to them. And we really focus a lot on thinking about healing happens in relationships. When we talk about how to help a person, we've developed plans and we've developed kind of whatever systemic things that we have in place, but we really have to think about, does that person who we are supporting, do they have a relationship that is significant to them? And are we connecting them to make sure that they do have somebody, that we understand that that's where that healing happens ultimately? First, we have to feel safe We have to think about what's happened to the person, and then how do we help that person connect to be able to heal. So what is trauma? We look at, you know, everybody experiences it differently. In this picture, you can see, like, it can happen in groups, it can happen individually, but the ways in which we address it can impact how a person heals through the journey of their trauma experience. I apologize, I'm having some technical difficulties advancing my slides. So people oftentimes, we think about, you know, what does trauma look like? And it can look differently to people. There's not one way that it might look to somebody or to everybody. People experience it on the individual. You know, it can be a community trauma that happens. You know, it can be family trauma, things that happen within the family system that everybody experiences. It could be just seeing something on TV that, you know, I think about the people out in California who are experiencing the fires and how, you know, you see that on TV. We experience it differently from afar versus the people who are there who are losing their homes, they're losing their valuables. Maybe they've lost a loved one as a result of this traumatic event. And so trauma really looks differently depending on how you experience it. Here's my slide, I apologize. So again, just this picture shows that, you know, we just experience things differently based on how and where maybe you are, or things that have happened to you prior to the traumatic event happening. I think about, I come from a large sibling group, and I have, you know, everybody has experienced different things within our family, and so my brother will tell a story, and I'll think, well, I don't remember it happening that way, but it's because I experienced it differently than he did, or I'll say something and he'll say the same thing to me, and I'm like, well, but you know, don't you remember this happened? And I'm like, no, I don't remember that. And it really attributes to, even when you are in the same family all together experiencing the same thing, it's really individualized of how the person may remember the event, how it may have made them feel, or just how the response happened within that traumatic event that can really impact the way a person responds. So it could also be that, you know, trauma looks like, you know, a divorce in a home, or extended stays in the hospital and the trauma that could happen with a hospital stay, and how a child may receive future visits to the hospital based on maybe they were an ill child or had a, you know, a surgery, a medical procedure. I think sometimes when, you know, there are things that happen to a person that there's not malicious intent, like a medical procedure where it was necessary and it, you know, it was really critical that the person had the treatment, but future experiences, because of that experience, future hospital visits, you know, could make the child fearful because of what they experienced prior to. Our ACE study, we'll talk about ACEs, which stands for Adverse Childhood Experiences. We'll talk about how all of these different pictures depict the types of traumatic events that happen to people, you know, whether it's divorce or neglect. Maybe someone in their home as a child, your parent had severe chronic mental illness, and how did that impact you in the ways in which you've experienced the world. So what is trauma? This is the framework for understanding trauma was developed by a working group of researchers, practitioners, trauma survivors, and family members convened by Samhsa. And Samhsa is the Substance Abuse and Mental Health Services Administration. This is the definition that Ohio adopted from the Samhsa model. And it's important because it creates a framework for understanding the complex nature of trauma. And so when we read through the definition, we kind of attribute to that event, experience, and effects. And we'll talk about what we refer to as the 3 E's in trauma work, and how those events, experience, and effects it really has on the person's mental, physical, social, emotional, and spiritual well-being. There are numerous definitions on trauma. For our purpose, though, in Ohio, we've adopted this definition for training purposes, really creating just a consistent foundation to make sure that we're all understanding what we mean when we say, what is trauma? So talking about the definition, the 3 E's in trauma are events, experiences, and effects. The definition of events is events or circumstances that cause trauma. And experiences highlights the fact that not every child or adult will experience the same events as traumatic. Just like I talked about earlier about, being raised in a large sibling group, my brothers experienced it differently than I did. I was the only girl out of 5. And so the boys experienced it very differently than me as a girl. Maybe that was just the way in which my parents parented different male versus female raising a child, and so they experience things differently. The effects of trauma is the identification of a broad range of potential effects that remind us that our response must be holistic. It's not enough to just focus on symptoms or behavior, but our goal is to support a child to learn and grow, or an adult to live a satisfying life. And so just thinking about how the effects are on the person, and then how do we help that person work through what's happened to them. So you'll notice a lot of our slides have, this is traumatic events as defined by a well-known person in the trauma work named Judith Herman. And you'll see that this is from 1992. And you might ask, well, why do they use a definition or a research way back in 1992? That's such old, 25 years ago, that's what they said that trauma was. And the reason for that is because it all still rings true. Trauma and the effects of trauma have not changed since this research was done. And so when we think about trauma, we think about traumatic events that have potential to cause reactions or responses from individuals. And so number 3 really is our focus when we think about traumatic events and the way in which it impacts a person. And that's the disruption of a sense of control, connection, and meaning. And when we think about the slides earlier, when we talked about things to remember, we talked about relationships are important, feeling safe. We can't feel connected unless we feel safe. And so this is that kind of universal approach that all victims of a traumatic event or survivors of a traumatic event, this is what they experienced in that traumatic event. That disruptive sense of control, connection, and meaning. So again, when we read through this slide, I won't read it to you. It just really attributes to that violation of control, connection, and meaning when we're talking about traumatic experiences. I like this slide because it also, too, shows you kind of the cycle of trauma. So one single event, it could be a set of circumstances, like things that have happened to you. Maybe it's historical trauma that's happened, generations before you, and that attributes to the ways in which you experience the world because of maybe something that's happened culturally, or maybe it's poverty. When you grow up in poverty, you have a different response to events, or how the ways in which you approach certain situations. Maybe it's chronic stress, and we'll talk about the impact chronic stress has on us as a reason why we have to look at a person's trauma history in order to really understand how to best support them. So there's a wide range of events that can potentially cause trauma. Trauma can be caused by events that the individual doesn't remember, such as events that occurred early in childhood. Trauma can be caused by events that are well-intentioned and necessary. We talked about before, like a medical procedure, like it was really necessary for this person to have this procedure or have kind of this long-term relationship in the hospital due to their medical needs, but it can still be traumatic. I think about just someone who's fearful of the dentist. You know, maybe something has happened prior to that made them fearful, or I think about raising my kids and taking them to all of their shot appointments as a baby, and then having to take my daughter in when she was ill, not for a shot, and how resistant she was to going back to that exam room because the only experience she's ever had at the doctor's office was getting shots. And so there was no way she was going back in that room to get a shot, and she wasn't feeling good to begin with. And so just thinking about how it's unintentional and it's necessary, but we still have to attribute and understand how it could possibly affect the person and what do we need to do to support them to be able to get through that experience. Trauma can be caused by an event that didn't happen to the person, but to a group that he or she identifies closely with. We think about, like, as in slavery or the Holocaust or the genocide of Native American people, those historical events that attribute to the ways in which a person identifies closely with and then has a different reaction maybe to the situation. Then there's chronic stressors. You know, over time, chronic stressors can accumulate to cause trauma. It also can have a major toll on your health overall, and we'll talk about that a little bit too. These lists that are created here and the different cells under abuse, loss, and chronic stressors, it's not an all-inclusive list. There are many, many more things that could be added to the list. These are just the things that we've kind of highlighted and looked at when we compare to the ACE study, which we're going to talk about. So the ACE study is a research study conducted by Kaiser Health. It's an organization in the center and also the Centers for Disease Control and Prevention. Participants who participated in the ACE study, the Adverse Childhood Experience Study, it compares adverse childhood experiences against adult status. And when this study was done, it was 17,000 patients undergoing physical examination provided by detailed information about childhood experiences of abuse, neglect, and family dysfunction. So they took those 17 patients who were actually in an obese clinic who didn't meet kind of the stereotypical, they were middle class, had health insurance. There wasn't kind of this kind of cookie cutter of what we would think about who those patients were. They were very, like I said, unlabeled, I guess I will say. So they looked at their ACE studies and the things that had happened to them, and looked at and can attribute the research to know that adverse childhood experiences are the most basic and long-lasting cause of health risk behaviors, mental illness, social malfunction, disease, disability, death, and healthcare costs. So the first two areas are more individual experiences versus the last area, which is usually a group. So the last area is usually a group of people. The first two are more individual experiences, how you personally have experienced things. The first time that this study expanded to household dysfunction, so it was really looking at, you know, it's got to go beyond just the individual. And so the results indicated that there were 10 common adverse experiences grouped in 3 general categories, and that's how we got to abuse, neglect, and household dysfunction within the research. And so it also let us kind of identify and know that, you know, growing up in a household with alcohol or drug users, maybe a member being imprisoned, a person being mentally ill, chronically depressed, or institutionalized, you know, living in that household, maybe some of that dysfunction, a separation or divorce, you know, domestic violence in the home, or maybe it's, you know, the child was raised without their biological parent in the household, or maybe there were emotional and physical abuse, but all of this led to understanding how those household dysfunctions have an impact on a person's life long term that can cause unhealthy coping skills, or maybe the opposite. Those are where they've learned those coping skills. And so it really helped. Folletti is attributing research from 1998 that he helps us understand that all of those ACEs, if you will, are what we have to look at in order to understand where a person's been. And we know as the ACE score increases, when we look at this, it increases a strong, probability that there could be an increase in health problems for a person. If you are raised in a household where, there's domestic violence, that high alert, always on kind of alert of not knowing what might happen, that can have some chronic stress to your body and some chronic health issues, heart issues, or, weakens that you're more susceptible to a stroke or broken bones, or lots of things can be attributed to of health problems when the ACE scores are high for a child and what they've experienced. So when we look at experience of trauma, experience is, the how, when, where, how often, what happened, kind of what happened for that person. And so the individual's experience of trauma may be profoundly affected by when, how, where, and how often it occurs. I think the one thing that's missing on here is who. The person, if it's a loved one or your parent or, a caretaker or someone sacred to you that has caused your trauma, that can have an even more impacting, devastating impact on you. So trauma can also result from a single devastating event, and we call those single episode traumas, sometimes called acute trauma, or it can result from multiple traumatic events over time. Most individuals served in the public system have complex trauma, which comes from experiencing multiple sources of trauma over a lifetime. I think about in the disability system, when we have, allegations of abuse or neglect for a person, whether in it being their caretaker, that really can have some really lasting effects on a person for the new caretaker that comes in who doesn't have the intention or the history with the person, and how that care could be impacted for that person of resistance, or, maybe they would respond differently to a new person because of what's happened with previous caretakers. Trauma can be totally unintentional, as when, sometimes our procedures as organizations, they're not intended to be harm, but, if you don't understand where that person has been, sometimes your organizational procedures can actually trigger a person to remember that traumatic event or have them respond in a negative way based on what's happened to them. So for an example, I think about like the routine practice of undressing for a medical exam can re-traumatize a person. A person who's been a sexual abuse victim, and then to be that vulnerable to have to undress for the medical exam. The medical exam or the medical professional may not know that that's happened to the person, and then the person has this response to their procedures and not even know that they're re-traumatizing a person. And so just really thinking about your own processes and procedures, and are they a universal approach to understanding trauma. Again, systems can unintentionally replicate the dynamics of an earlier trauma causing re-traumatization, which I explained. And trauma can occur from hearing about, watching, or interacting with others who have had traumatic experiences. Sometimes hearing other people's stories can make us remember things that have happened to us, and then we start to have like those feelings of what's happened to us too.
Hey Beth, this is Diane. I just wanted to give you a quick time check.
Okay.
We're about 15 minutes away.
Okay. I will speak along. So the effects of trauma, on an individual can be conceptualized as normal response to an abnormal situation, and that's what we have to really think about is, the person isn't responding in a bad way, it's just they're doing the best they know how to. And we know, we talked about earlier, the prevalence of adverse childhood experiences. The higher the ACE score, the more prevalent you're going to see a person having from what's happened to them, experience or reaction to what's happened to them. So when we talk about how trauma affects us internally, we have to think about the brain is that bottom-up organization. We can't talk about trauma without thinking about the internal experience that also happens. There is an internal struggle that happens when there are external impacts happening to the person, and there's a physical reaction that a person experiences depending on how trauma has affected them. I won't go into too much detail about the brain, but there are lots of research and some really fascinating information out there about what happens to the brain when a person is triggered by their own trauma, and also too how trauma impacts the development of the brain, and where you know, high doses of cortisol and the hormonal response happens that helps a person, that impacts a person to not be able to have coping mechanisms because the brain internally is not feeling safe and is having a response, and then the person also is experiencing that as well externally. Lots of good research out there about that. So signs of trauma, you know, a person may have flashbacks or frequent nightmares, be sensitive to noise or being touched, always expecting something bad to happen, and maybe just not remembering periods of their life, which is very normal, very, you know, a very normal response to something traumatic. Sometimes it has to do with how the brain is processing the information and the ways in which the trauma has been dealt with too. Or maybe just feeling emotionally numb. Again, just however that person is coping. These could be some just universal signs of trauma that have happened to the person. When we think about a person's experience, you know, oftentimes we think like their behavior is problematic. But when we think about it from a trauma perspective and a trauma lens, we're really thinking about this is their adaptation. And so there is this fight, flight, or freeze response that happens depending on the person's own coping skills. I always think about, too, when fight, flight, or freeze, if you're a caretaker and you're caring for someone who is a fight response, let's use for example, and you also have fight is also your response in a critical crisis situation, sometimes that's the conflict and that's the problem, is because both persons' adaptations or response to a traumatic event can conflict and be even less helpful because both people are seeking that control and power because that's their adaptation response. So coming from a trauma lens, instead of thinking about what's wrong with you, we think about it as what's happened to you. And you've probably heard me say that numerous times today as we've gone through the PowerPoint, but it's really about what's happened to the person. And when we talk about what's happened to you, there's key considerations that we as caretakers, support staff, have to think about, that all behavior has meaning. And symptoms are adaptations, and that we build success on deficits, and it's just the brain's way of protecting the body. That person's response is just the brain's way of protecting the body and what it knows best. So the science on the ACEs, again, the new lens through which to understand the human story. When we look through all of the lists, the one key important one is how might we better prevent, treat, and manage illness in our healthcare systems. And so thinking about those policies and practices and procedures that you have in place, do they truly come from a trauma lens? Are we using a universal approach to treating the person? And then what can we do differently? Really considering, you know, when we look at the previous slide, the symptoms are adaptations. And so you want to build on those deficits, build on the success, not the deficits, and looking at all behavior has meaning. And so do our practices and procedures prevent that from happening? And then are we also, during treatment, looking at it from that trauma lens? So the cost of trauma, again, trauma is a major driver in medical illnesses. And so that's one reason why it's really important that we start to think about people's ACE scores and their assessments and what's happened to them, so that we can prevent some of these chronic illnesses from occurring in a person's life. We talked earlier about Samhsa, and that's the model that Ohio has adopted. And so here are the 6 key principles of a trauma-informed approach. That safety is always at the forefront, that's the number 1. That you are building trustworthiness and transparency within your systems and with each patient that you see. Peer support, collaboration, and mutuality is happening. You're inviting the person to be a part of any decisions that are being made or policies and procedures to really look at, are we addressing that universal approach to trauma-informed care. Empowerment, voice, and choice, that's key to it all as well. And choice isn't about a menu option. Choice is really about helping that person see their possibilities and what can they choose from to make sure that they are not experiencing that disruption of sense of control, and that they are also attributing to their decisions. And looking at cultural, historical, and gender issues, considering all different types of traumatic events that may have occurred in that person's history. So this is Samhsa's definition of recovery. This definition was developed by a group of individuals who had been diagnosed with mental health and substance abuse problems. They were asked by Samhsa to develop a common definition and a set of principles for recovery. Recovery has a breakthrough in mental health because so many people with mental health diagnosis thought they would never be able to overcome their problems. It was also a breakthrough because it really emphasized that what people want is a meaningful life. It's not just, not only does it help in reducing or controlling maybe those symptoms or problem behaviors, but it really helps a person get connected with what is it that they want out of their lives and to have those healthy coping mechanisms. So recovery has now been adopted as the basic framework by many behavioral health programs, and we often use the term healing instead of recovery when we're talking about trauma. That's the basic message is the same though. Everyone has the possibility of living a satisfying and meaningful life regardless of what happened to them or maybe what diagnosis has been given to them. It's really about just helping that person have a satisfying and meaningful life. So just so what can you do? Oftentimes we hear people say, this is all great, but how do I know that I'm coming from the trauma approach? How do I know I'm coming from that trauma lens and really understanding what it means? And so what you can do is just treat everyone with universal precaution. It's not about putting on, like, when I think about universal precautions, like literally like the gloves and all that, that's not really what we're talking about. We're talking about kindness, like understanding that the person may be responding the best way that they know how, and to not see it as a symptomatic thing. But really just understanding that maybe something's happened to them and that's why they're responding the way that they are. And just to assume that everyone has experienced trauma. Consider the implications of the work that you do with the outcomes that are experienced by the individuals we support. You can also help by creating an environment that promotes safety. When we talked about the definition, that was kind of key, that safety, without safety and a person feeling safe, connection can't happen. And so really, as you're talking with patients or with the person you're supporting, just paying attention to physical space, your tone of voice, maybe the loudness of the music in the room, side conversations, and eliminate anything that may be intimidating or maybe anxiety-provoking. And avoid re-traumatizing individuals within the limits of safety policies and procedures. We talked a lot about, are your policies and practices and procedures coming from that trauma lens? Use approaches that help calm when possible, and kind of being mindful, like, are they confrontational or is it really calm? And so with a more calm approach, it allows that person to feel that external feeling of control that may help them respond differently. And thinking about how your work impacts you and making sure that you're having good self-care, taking care of yourself. And we have to think about how when we know all this information and approach, it comes at a cost in various ways. We do some hard work, and so looking at how vicarious trauma and compassion fatigue impacts that work. So you're working with persons with histories of trauma, maybe thinking about your own and how, like, have you attributed to your own history and you there to be able to help another person work through theirs. So again, just another slide to remind that there is a cost to caring, and we have to make sure that we're taking good care of ourselves and we're taking care of each other in our own work. And so what helps, this is just a quote that says, sometimes we need someone to simply be there, not to fix anything or do anything in particular, but just to let us feel that we are cared for and supported. I think that sometimes when we are in the helping field, sometimes I feel like I call it the fixing field. We feel like we have to fix everything, and sometimes healing happens by just somebody saying to you, someone who's sharing their story, and your response is, gosh, thank you for sharing. You know, I'm really sorry that happened to you, or, you know, it's not about fixing it or attributing their feelings or maybe what they're experiencing, but just listening. And then the empowerment, listening is a very empowering and powerful approach to helping a person work through what's happened to them. And just having empathy for the person, you know, is the easiest, but empathy is a really hard thing to do because it leaves us a little more vulnerable to our own stuff that's happened to us. And so really, can you lend empathy to that person versus sympathy? And that makes all the difference too. So what can we do? Again, just kind of a list of things, looking at, you know, provide consistency, prepare people for change if that's something that's hard for them, increase choice by making more opportunities, and don't take it personally. You know, the person, again, you know that you are probably not the person that's caused their trauma, but the ways in which they're responding, it's just the best way they know how. And so really thinking about that and just provide, you know, increased levels of support in helping that person kind of work through what it is they're experiencing, whether that's in the long term or in the short term, and just being there, giving that lending listening ear. I think it's hard for us to, when you look at this slide, but the one thing that, you know, to really look and take away from is above all else, do no harm. And so basically what that means is you don't always have to have the right thing to say, but know what not to say. So just attributing that person and their bravery and sharing with you, and you know, not having to tell them how to fix it, just listening, and just know that you don't always have to have the right thing to say. So why does this matter? You know, it's a way of being. It's understanding what people have gone through or are going through. It's a way of talking. It's a way of offering care. And sometimes, too, it's just a way of having a different perspective in the world. Lots of things, lots of bad things happening. So, and lots of bad things happen to people, but just being able to be there and not attributing to the bad things. So saying hi to somebody, or, you know, just showing that kindness of humanity, basically. It's just, again, a way of being, and it's important because you just never know how your care impacts a person and how it has lasting effects on the person. Tip 57 is the framework also through the Samhsa model. That is available if you want to look up. There are some, this is a great resource and a guidance for trauma approach. This is a very short, brief, 30,000-foot view of what trauma-informed care is, and there are lots of more in-depth trainings and lots of resources and tools offered free through the Ohio Mental Health and Addiction Services website. What this slide just shows, it just illustrates that empathy, coming down on that person's level, asking what's wrong and how can you help, and giving them, offering that support that you feel like, you know, they may need and could make them feel better. And then asking them, you know, does it help? You know, do you want me to stay? What can I do to help you? And giving that person that voice, choice, and control. So this is my contact information. Like I said, from the Ohio Mental Health and Addiction Services, there are, I think there are just a little over 150 trauma-informed care trainers in Ohio that can come and do a more in-depth 101 training for your agencies. And if you ever want to find out who those trainers are and their availability and to come to your agency to give a more in-depth training, this is my email address and phone number. I'd be more than happy to connect you with those trainers. So again, I thank you for the opportunity. Thanks for tuning in today, and thank you. So, yeah.
Thank you so much, Beth, for that great overview of what trauma-informed care looks like. And we'll look forward to the additional webinars that I think we've been sending out, and you should have the dates for those, but we'll make sure that everyone gets them again. And again, thanks so much for giving us the foundation for trauma-informed care. Appreciate it.
Thank you.
And there should be a survey that pops up if you all can just stay on the line and briefly give us some feedback. I'd appreciate it. Although there may be a slight technical problem, so please stay on the line. Oh. When you log off I'm sorry, I've just been informed, when you log off, then the brief survey will follow. Thanks, everyone. Have a great day. Beth, I think we're done. Are you there?
Yeah,
Okay.
Do you need me to log off? Anything you need from me?
I don't think so. Jonathan?